right, let's get started. Hi, everyone. I am Katie Berry. I am a fifth-year PhD candidate here in the Division of Epidemiology and Community Health. And I have the lovely task of introducing our speaker today. So Dr. Andy Fenelon is an associate professor here in the Division of Epidemiology and Community Health and a member of the Minnesota Population Center. He's a demographer and population health scientist who's interested in the social and policy determinants of health. Specifically, he studies how housing policy can improve health and well-being and reduce inequalities across the life course. Before coming to the University of Minnesota, Andy was an assistant professor of public policy and sociology at Penn State. And he has a PhD in sociology from the University of Pennsylvania and a bachelor's in geography from UC Santa Barbara. Thanks to his background in geography and demography, Andy is full of fun facts about US population and American cities, including his all-time favorite city, Minneapolis. In fact, the only thing stronger than Andy's enthusiasm for Minneapolis is the division's excitement about him joining our faculty last summer. In today's talk, Andy will be sharing his research on housing assistance programs and lead exposure. I had the privilege of seeing Andy give a similar talk at the Minnesota Population Center a few weeks ago, and the work was so compelling that I'm here for an encore. So I hope that you all will enjoy hearing about this important research as much as I did. And please note that I'll be accepting applications for the Andy Fenelon fan club afterwards. Andy, before you get started, I'd also like to present you with the coveted W. Bob glass, which you get for presenting at seminar. Best of luck.
Thank you so much, Katie. Yeah, this is really fantastic, and as you can see, I'm already a W. Bob booster, so this can go. Yeah. Any questions? So as Katie mentioned, I'm newish to the division. I've been here about 7 months. I got here at the end of June, but I honestly do think that we're just now reaching the point where I don't feel new anymore. Like I feel like this is where I am. This is the place that that feels like home, both academically and personally. Although I do want to say, and I'm not going to name any specific names. You all know who you are, in fact, most of you. I don't know why Minnesotans are so wimpy about the winter. It's great. Bouncing between the 30s and the 50s, plenty of sunshine. I've been riding my bike all this week. Yeah, but everyone always says that. In fairness, I do recognize that it is warmer than average. And when we had that very short cold snap, I became one of those Minnesota people where right after, when it popped back into the 20s, I was like, oh, it's so warm. Yeah, and so I understand where you all get it. Today I'm presenting work on housing assistance and lead exposure. So I'm a demographer by training. I'm interested in population health, and most of my recent work is on housing and housing assistance programs. And this piece is part of a larger project on housing assistance programs and their effect on environmental risk exposures. Now, I am not an expert in environmental risk. I didn't even have any particular interest before joining this team, but I think one thing that defines me as a researcher, and a lot of demographers actually, is that we collaborate almost exclusively with people outside our discipline. I work with people in sociology, in public policy, in public health, epidemiology, environmental health, and this is one of those collaborations that I was just really interested in some of the compelling experience that environmental health people could bring to my knowledge of pop health and policy. And then the subtitle here is public housing actually that bad? And we'll get into that a lot more during the talk, but the idea here is that you could all be forgiven if your understanding of public housing was what you learned in the news and that it's all bad all the time. Okay, so what I'm going to present today is a project on housing assistance and lead exposure. And Sorry, that was just a little bit of a Groundhog Day joke. Yeah. And I don't know if you noticed, but this morning the groundhog did say that we're gonna have an early spring. I hope that some people were feeling very awkward about that.
Too much time in Pennsylvania.
Yeah, so this is a collaborative project, and I want to acknowledge the other members of the team, especially Mi-Sung Chu, who's now at Tufts. She was the postdoc on this grant team, and she wrote the first draft of this paper. Ami Zota is an environmental health scientist. She's the PI. She's at Columbia, and Gary Demkowicz studies environmental health and public housing. And this is funded by HUD of all places. Just kind of a roadmap of the talk. I'm going to first not talk about housing. I'm first going to talk about lead, actually, because lead is something that a lot of public health scholars think about. It's something that's gotten more attention in the past decade, despite the fact that it's actually gotten less prevalent. And then I'm going to move into talking about public housing as part of the government's approach to funding rental assistance for low-income families. And so I'm additionally going to talk about other programs that we have going on. I'm also going to talk a little bit about how we think about conceptualization of housing and how it affects health. And why this is a really, really interesting topic, something that people think about, even if they're not housing scholars, even if they're not public health scholars, but why it's actually very difficult, right? So if you were to ask people, what are the social determinants of health? In a list of 5 things, housing would almost certainly be in there. But it's not that easy to study because a lot of data sources that we would use don't have information both on housing and health. And so I'm going to hopefully convince you that in order to study this really well, we need linked data. I'm going to move from there into my approach, which is a quasi-experimental technique. What I find, which I think are really compelling findings, and then I want to end kind of with taking a more critical approach to media attention surrounding housing programs. Anytime the media covers something that you know a lot about, it's probably frustrating. And this is my example, and so maybe you can take an example from your own work. Okay, so lead. Now, I don't think I have to convince anybody in this room that lead is really bad. It's really, really bad. It has a lot of negative effects on the individual, negative effects in society, and I would argue it is one of the biggest policy errors that we made during the 20th century. And that's not a limited statement. I mean, this from the country that brought you Jim Crow and the Vietnam War, and the smoking epidemic. But lead really has negative effects in lots of different areas of society. And it was in everything for a time. Everything from gasoline. It was in our air. It was in paint, so it's in all of our houses essentially. It was in toys. It was in turmeric, the things that we put in our food. And knowledge of its negative effects has been known much longer than regulation regarding lead has existed. But one important thing to recognize is that although a lot of the focus of lead research in public health, social sciences has focused on kids, and for good reason, because we know that lead permanently damages kids' brains, leads to long-term reductions in outcomes of all sorts. Recent work actually shows that lead's bad for everyone. That lead is bad for adults' health, and prolonged exposure to lead for adults has negative health effects. And part of the reason that I was interested in it for this project is that most of the contemporary sources of lead exposure are residential. That nowadays, thankfully, we've gotten lead out of a lot of things that it used to be in. It's still not wonderful being next to this freeway, but in 1971, it would have been absolutely terrible. And so most of the time now, we're getting exposed to lead at home or in our neighborhoods. Now, if you look at the history of lead and how public health views lead, you see this funny moving target of what lead levels are okay for people to be exposed to. And they start real high because that's where people's lead levels were. Then they get lower, and then they get lower, and then they get lower as we did a better job of taking lead out of things. But it's only actually in the past few years that we've sort of come to this consensus that no level of lead exposure is acceptable. So there's no level of lead exposure that's safe, at least according to the CDC. But, people do love to have cutoffs. And so in many cases, levels above 3.5 micrograms per deciliter are going to mean that you're probably going to be involved in some sort of clinical follow-up. And so if you're a kid and you come in and your blood lead is taken and you're up above this level, there's going to be some concern. And another thing to recognize is that the level of exposure to lead matters, right? So if you come in and your blood lead is very high, that's really important. But also prolonged exposure is really important. So if you come in and your lead level is 3.5, getting it down really quickly is important. And so that's why interventions to reduce lead are pretty important. Okay, so now a little bit of the bad news for those of us in this room. This is a fantastic piece that came out in NHANES a couple of years ago by a couple of demographers at Florida State. And they essentially used historic data on blood lead to estimate what fraction of birth cohorts experienced lead levels above what we would consider acceptable. So 5 micrograms per deciliter. And one piece of good news, let's focus on that too first before we get too far, is that we've actually been really successful at removing lead from people's bodies. It's now pretty rare to find kids with blood lead levels above 5 micrograms per deciliter. It didn't used to be. It not only used to be common, it used to be essentially everybody. So those of us born between, 1966 and 1980, Generation X. Okay, so Generation X, that's bad news. Things got a lot better. I was born in 1985, so I'm right here on the cusp of a rapid decline in lead. So maybe I was one of the lucky ones, maybe not. But born in these ages, very few people were lucky. Born more recently, it's much less common. But there's still huge disparities in who ends up in that group. We'll talk about that in a second. And I do want to emphasize that it's not just that essentially everybody had blood lead levels above 5. The average blood lead level in childhood for those cohorts was around 20 micrograms per deciliter. And if you showed up at the doctor now with blood lead levels that high, it would be an extreme emergency. And that was the average. So we know from decades of work that elevated lead exposure is associated with a ton of different health outcomes, both in the short term and in the long term. And we couldn't even list them all, honestly, because there's research from all areas of epidemiology, people who are interested in different diseases that have found lead implicated in elevated levels of digestive diseases, inflammatory conditions, cardiovascular, respiratory disease, even dementia. And that's not an exhaustive list. And then beyond health, there's actually a lot of work about lead exposure and behavioral and cognitive effects. So the effects are everywhere. There was a paper from University of Minnesota folks a couple of years ago that had a really unique design linking where people live in the 1940 census to a modern survey that had information on cognitive outcomes. And so they used where they lived in 1940, linked that to information about where lead water pipes were, and then about the pH of water, because certain pH levels leach lead into the water better than others, and found that people who lived in places with lead pipes and either acidic or alkaline water had reduced cognitive scores up to 80 years later. And then, I mean, kids are not choosing what types of pipes are in the ground. There's also some, and I will say this is controversial. I don't necessarily subscribe to this way of thinking, but there is some attention to whether lead exposure is implicated in the rise in crime seen in American cities in the mid to late 20th century. Now, what I do want to say is at the individual level, it is almost absolutely certain that extreme lead exposure is associated with aggression and violent behavior. Whether it actually is true at the population level, that's more controversial. I'm not sure I totally believe it, but there's whole literature on this. So just to make the point that lead, the negative effects of lead are everywhere. Nowadays, we're mostly getting exposed to lead through four sources: soil, water, paint, and dust. And yes, that's only four sources, but honestly, that's essentially everything, right? Like those are the things that we come in contact with every day. So it's in the soil in many cases because it used to be in the air and the soil retained it from gasoline. It's in the water because lead pipes still exist, as we saw with the Flint, Michigan crisis. It's in paint because many of us probably live in houses that were built before lead paint was banned. And this is not in support of lead, but lead paint's way better. Like there's a reason that they continue using it. It lasts much longer. And it's in dust from all these other sources in our neighborhoods. And there's actually a seasonality to lead exposure because in the summer, people have their windows open and dust from surrounding construction sites or construction sites within their own home moves material around. Okay, so understanding then how housing fits into this is pretty clear, right? These are things that we get exposed to at home. But understanding how housing affects lead exposure does fit into a larger literature about how housing affects health. And there's a fantastic piece from about 5 years ago now that develops a framework for how to think about how housing affects your health. And they had this really clever heuristic where they chose four C words that kind of fill in the mechanisms through which housing will affect your health. Costs, how affordable it is, whether you can afford your housing. Consistency, how stable it is, whether you have to move around a lot. Conditions, so the quality of the construction, whether you're crowded, the quality of the materials. And then a contextual piece, so what kind of neighborhood is it in? What other services or amenities do you have access to? Now, although the relationship between housing and lead could conceivably fit into a lot of these, the main focus for clear reasons is on condition, right? So lead exposure is going to be higher if the quality of your housing is lower. And one quick aside about that. Research on housing quality is not as common as it used to be. So, and there's good reason for that. So housing quality used to be pretty poor on average. So if you look back into the early 20th century, it's something like a third of all housing units were deemed inadequate to live in, right? So we're not just talking about peeling paint or broken floorboards or pests or anything. We're talking about extremely low quality housing, and a lot of people experienced these housing quality issues. And this is actually a major focus of research on housing and health for a long time, going into the second half of the 20th century. Today, thankfully, housing quality concerns are much less prevalent. It's very, very rare to find extremely inadequate housing. And so as a result, affordability is the primary concern. So this is not part of this talk, but there's actually a widespread housing affordability crisis. About half of renters pay too much for their housing. There's a lack of choice in where people can live. It's a big issue, and so not to diminish that. But the focus on affordability recently means that there's less research on quality. And that's understandable, but quality, even though housing quality has improved a lot, it's a major disparity mechanism because who experiences low quality housing is now largely extremely disadvantaged families. And so it's a huge mechanism for disparities by income and race. And this is where housing programs come in, right? Because one thing the government can do is ensure that everyone has access to decent quality housing. And so the question, how bad is public housing, has a lot of different answers. But the answer that you would come to if you read the New York Times, the newspaper of record, would be that it's pretty bad. That public housing is this failure of big government, and we made a lot of mistakes. It's time to get rid of that and focus on the future. So this is a smattering of articles from not a long period of time, just a few years, where the New York Times was criticizing the New York City Housing Authority for all sorts of quality issues, many related to lead, actually, but related to all sorts of other things. And I don't want to diminish issues with New York City public housing or public housing more broadly. What I do want to say is that if you were a New York Times reader and you're not reading every single article, you're looking at what is covered generally, you could be forgiven if you came to the conclusion that public housing was a huge disaster, lack of investment. We made a mistake. This is what happens when we let the government do things the private sector could do. But a little history on public housing. It's not always been this way. Public housing grew out of the New Deal in the 1930s. The federal government provided funds to construct housing developments in 50 cities before 1940. Minneapolis had one, the Sumner Field development. And these are some examples from other places throughout the US. Now, what's interesting is that these buildings are beautiful. These are really high quality housing. And it's true that the quality of construction for early public housing developments was high. Higher than not only what people were renting in the private market, higher than the median quality for housing construction at the time. Okay, but part of the reason for that is because the early public housing program was not focused on the poor. The early public housing program was oriented towards what was called the submerged middle class. So middle class families that were expected to be upwardly mobile, and all they needed was a really good environment away from all the worst people of society. So the motivation for this program was not always positive, but the outcome was quite positive. So we had very high quality construction, we had relatively low rents, and the amazing thing is that most of the developments from that period are still around. Sumner Field is not. That was demolished in the late 90s, early 2000s. The rest of these are still around. They're still used as public housing. And most of the developments from that period are. Now, moving into the 1950s and 60s, public housing began to be oriented towards the poor. And that was required by an act of Congress in 1949, that public housing be reserved for poor families, and that it be involved in urban renewal, slum clearance at the time. And so the structure of public housing looks very different. The quality of construction is much lower, density is much higher, the neighborhood integration is much lower. And this is honestly probably what most Americans, and maybe most people in this room, have in mind when they hear the term public housing, right? So large project towers, architecture that is defined by the 1950s and 60s, and very little neighborhood integration, right? Like these are the projects and they are set apart from the rest of society. In the 21st century, public housing construction has learned from some of those mistakes. The structure of developments is different. They're more integrated, they're much less dense. The architecture is not quite as recognizable. And so there are some positives with the new model of public housing. The one downside, there's very little built. I had to dig quite deep to find these new developments. There was a moratorium on new construction of public housing in the 1970s, And there's been very little new public housing development since then. And that's where we get the other housing assistance programs in the US that are not public housing. So to distinguish public housing from these other programs, public housing is owned and operated by the government. So there are public housing authorities in 3,000 localities throughout the US. They're responsible for maintaining and housing families in government-owned developments. In contrast, the voucher program provides a subsidy for families to rent market rate units in the private market. And so families will pay 30% of their income. The voucher will subsidize the difference between what they can afford to pay and what the rent is up to a certain level. And then they're allowed to move anywhere, in theory. Multifamily housing is a variety of other programs in which privately owned developments maintain a certain fraction of units for assisted families at affordable rates. So many of these developments are previously public housing developments that have been renovated into multifamily housing, but they're privately owned.
Maybe I'm very naive when it comes to assistance programs for housing. Is it federally driven, state driven? Is the federal government giving the money and requiring the states to mandate how it's spread?
Yes, great question. This is one of the few programs that is completely federally funded. States have no role, but localities have a role in that the public housing authority is often staffed by people either appointed by local government or at least related to local government. And that's a legacy of racism in that during the early parts of the program, localities wanted to continue segregating housing projects, and they wouldn't have been allowed to if the federal government was kind of monitoring these things. But as a result, today, it's locally operated but federally funded. Okay, so how might these programs be related to housing quality? Well, one reason is that housing assistance units actually have to be inspected. They actually have to meet a quality standard. Housing voucher units are inspected when a family moves in. And if the inspection doesn't meet a quality standard, then the landlord cannot participate in the program. And then typically voucher units get an inspection every so often after that, usually annually, but there's a lot of administrative issues. Public housing is inspected much more regularly, every couple of years or so, and there's really no way for public housing developments to opt out of this. They actually get a score, and you can look up what the housing quality score is for housing projects. But another thing to recognize is that affordability actually comes in here, because low-income families, when they're searching for housing outside of housing assistance programs, they're quite often sacrificing housing quality for affordability. So they're renting lower quality units than they would like to live in because that's what they can afford. And so housing assistance, by increasing the affordability of housing, in theory provides more options at higher quality point than people would be able to afford in the private market. Now, I said before that studying this is hard. Now, I think studying this is really, really hard, and for a lot of different reasons. That without the right data, we're limited in a lot of different ways. One is that we're talking about a pretty small population. Only about 10 million individuals receive housing assistance in the United States, 5 million families. And so essentially any survey we take is going to have very small samples of this population. In some cases, what we can do is get 100% data from a particular housing authority or a particular locality. But then we're dealing with limited geography, and because there's 3,000 localities that are all operating this program a little bit different, and there's differences across places, and we're dealing with maybe some not so generalizable issues. A lot of larger surveys do contain questions about whether someone is receiving housing assistance. But the question is, are you receiving housing assistance? Okay, and that's great. That's the best we can do in a lot of cases. But people don't necessarily report whether they receive housing assistance very well. So in some work that some colleagues and I did a few years ago, we found that half of families who we knew from administrative data were living in public housing reported that they were not receiving housing assistance. There's also self-reports of outcomes. And in public health, we often want people to self-report their outcomes because they know their health better than any clinician could find out in a half an hour meeting, right? So people know things about their health that are tough to pick up from a doctor. But for some outcomes, we really don't want them to self-report it, and lead is clearly one of those, right? People don't know their lead level. Even if we asked, has a doctor ever told you that your lead is elevated, that would require having been to a doctor and having their blood lead taken. So this is one outcome where we really, really don't want people to self-report. And the last is selection bias. People who receive housing assistance are very different from those who don't on a lot of different dimensions. Now, I have had this slide in talks many times, and it's only recently that I've been told that the term selection bias means something different to epidemiologists than to social scientists. I don't care. For the time being, we're going to use my term, which essentially means that there are factors that get people into housing assistance that are going to be tough to measure. We can talk later about your meeting. A final thing before we get into what I'm actually doing is that people wait a long time for housing assistance. Unlike other safety net programs in the US, housing assistance is not an entitlement. So just qualifying for the program doesn't mean you get it. There's a severe shortage of units relative to the number of people who want them. And as a result, families have to wait on average 2 years after applying for assistance to actually get a unit. This is terrible for families who are having to wait that long. They typically are in need of stable, affordable, high quality housing, can't get it, but it does create the conditions that provide a reasonable comparison group for those who are receiving housing assistance, because unfortunately people have to wait for a substantial amount of time. Yeah.
Is 2 years the national average? Because I know in many cities it's much, much longer than that.
Yes, so two years is the national average. It varies quite a bit across places, and there's some difficulty in standardizing the measurement of what we mean when we say the wait time, that just spending time on the wait list is not necessarily the whole wait.
Yeah.
And for the most part, you don't get the extreme wait times except for a few isolated cases. So they're like, every so often you'll read a story where someone's been waiting 20 years for a voucher, and that's quite rare. But it's not rare to wait 5 years.
I also have a wait list question. Is this 2 years, including like people all the way from folks who are unhoused waiting to get a voucher, or people who are already housed in market rate or private housing and then waiting 2 years to get into public or something?
It's both, yeah. So it's kind of the time from when you're on a list to when you get in. All right, so what am I doing? The research questions are pretty simple and standard. I want to give some clear results. There are nuanced findings that we can talk about, but I want to answer these two questions. What's the effect of receiving housing assistance on lead exposure? And does this effect differ by housing program? So we're focusing here on public housing, but we also want to look at vouchers and multifamily. I'm using an innovative data source, which is the National Health and Nutrition Examination Survey, NHANES, which many of you might have used, be aware of at least, linked to HUD's administrative records on housing assistance participation. And there are three major strengths of this particular linkage. The first is that we have measured blood lead. NHANES actually comes, they take blood, they measure all sorts of things, not just lead. It's hard to imagine a survey like this even getting started now. And response rates have been dropping even for NHANES, but in the grand world of surveys, the response rates are very high. We have administrative data on HUD participation. So we know from HUD's administrative records who is participating and who's not. We don't ask participants to self-report, although in not this survey, but another, they do self-report. And so that's how we were able to compare the two. And because the HUD administrative record is longitudinal, we know not just whether someone's receiving housing assistance, but when they got in, when they're going to leave, whether they're going to get it in the future. So we have this information on entry and exit dates. So this is kind of how it works. And it's a long period of time. We have 21 years of the administrative record. We have 20 years of NHANES. And then once people provide identifiable information, they can be linked. And I'm not going to talk in detail about how the linkage is done. I didn't do it. We can talk afterwards if people are interested. We can link people to their HUD assistance episodes, whether it was during the time of interview, before, after, both. We can link people to multiple episodes. And of course, we can find out if people were living in HUD housing assistance when they were interviewed. The two outcome measures are the continuous blood lead level, which is log, so we're looking at geometric means, and then a dichotomous measure of elevated blood lead. And thankfully, because blood lead levels above 5 are very rare, we're using the clinically relevant 3.5 micrograms per deciliter. And we're focusing on individuals 6 and older. Okay, partially that's because there are some folks who I used to work with at NCHS who have done this pretty well for individuals 1 to 5. They use a different approach slightly because their sample was so small, but we don't want to repeat what they've done here. But also because we're interested in how lead is distributed in people across the life course. Now, as I mentioned before, housing assistance is not randomly assigned, right? So people are not being selected to receive or not receive housing assistance. And those who receive housing assistance are different in many ways from those who don't. And those ways are substantial. And people who are receiving housing assistance differ not just from the general population of folks not receiving housing assistance, but even if you look at kind of the population who would qualify, poor renters, there still appears to be a lot of selection. So self-rated health is much poorer than the general population, as well as low-income renters. Rates of disability are much higher. Even educational attainment is less favorable. And so I just want to emphasize that there are a ton of differences here. We're really picking up an extremely disadvantaged population. And even among kids, we're seeing these differences. So if we compare kids' mental health, those who are receiving assistance to those who are not, we see that even among children, there's selection into housing assistance. And so because these differences are so stark and so large, we're not going to be able to statistically adjust for these differences. There are just too many things that are unobservable that select people into housing assistance. So one example is you're living in a household, you are earning an income, all of a sudden there is a death in the family, and your housing is gone, and you can't pay your rent, you're evicted, then you apply for housing assistance. That's really hard to capture in a survey. But we can use the wait list. So these are 2 individuals who both have HUD experience at some point. Now the survey shows up to interview them here in 2000. One of whom has already gotten in. They're receiving housing assistance when the survey comes. One hasn't. We know from the HUD record that they do get in the following year. We know when. The interesting thing is they might not know in this situation. The NHANES shows up to interview them. They answer questions. Blood is taken. They don't know the future, but amazingly we know their future because of the beauty of the administrative record. And so if we look at descriptive characteristics for those receiving housing assistance and those not receiving housing assistance, so kind of a naive comparison, there are huge differences, right? So those receiving housing assistance are more likely to be women, more likely to be non-Hispanic Black, more likely to have less than a high school education, much more likely to be in extreme poverty, much less likely to be currently employed. But when we switch the comparison to this waitlist group, it looks very similar, right? So a lot of those differences that we saw comparing everyone not receiving housing assistance are gone. And this is just to provide some assurance that this comparison group is reasonable. That we're picking up a similar group of people, and it's only because the survey came to interview them before they got in that they're not receiving housing assistance. Okay, so quick rundown of the results. These are models predicting the outcomes. The main comparison here is those receiving current assistance. The comparison is those on the wait list. Blood lead level is 12% lower, 11.5%. And this might seem like a small effect, but I do want to say that with lead levels as low as they are, getting movement on them is pretty significant. We also find that there's a substantial reduction in the odds of having elevated blood lead, so 3.5 micrograms per deciliter or above. And this effect is not minimal. So it's almost a halving of the fraction of people who are in this category, from 9 to about 5. Now comparing programs. So first, public housing. Public housing is terrible quality. It's a failure of government, and it's actually where we're seeing a lot of the action. Almost a 20% reduction for people once they get into public housing compared to the wait list. Housing vouchers, non-significant. It's in the right direction. The samples are not enormous, and so I don't want to read too much into this to say that there's no effect, but it's at least much less large. Multifamily housing, right in the middle, a still significant reduction. And one thing to point out is it's not just that people are living in terrible housing before they get into public housing and then they get into slightly less terrible housing. But we're actually seeing blood lead levels lower for public and multifamily housing than perhaps choice voucher families. Okay, now the next outcome, the odds of elevated blood lead, and the findings are pretty consistent. A substantial reduction in the fraction with elevated blood lead in public housing, right direction, not significant for housing choice vouchers, a fairly large effect for multifamily housing, not significant, so there might be some statistical power issues. These groups are not especially large. Okay, so just a quick summary of the results, and then I want to try and convince you of something. First is that housing assistance recipients experience considerable economic and health disadvantage. So this is not my finding. This was known before I started this project. Lots of other people have studied this. People receiving housing assistance are arguably the most disadvantaged, maybe 1 to 3% of the population. And I think sometimes that can be problematic, because if you just do a naive comparison, you can say, look how bad public housing is. The people are so unhealthy and poor. But that would be a huge mistake, as we know in the research world. Because access to housing assistance programs reduces your blood lead and your odds of elevated blood lead relative to what you were experiencing before you got it. And interestingly enough, these effects are strongest for public housing, non-significant for housing vouchers. So what are the implications? How bad is public housing? Public housing is good, actually. Right, and so one thing that's interesting is that if we found that public housing had no effect on your lead levels, that in itself might be interesting, because the expectation is that public housing is making things worse for you. But it's actually making things better. So, I mean, despite the conventional narrative that public housing is having negative effects on people's outcomes relative to what they would experience otherwise, we're finding the opposite, that people in public housing are enjoying better quality than they did before entering. And I think another implication is that quality still matters, right? That there is actually an important conversation to be had about what housing programs can do for housing quality and what effect that has on health. But if you do a quick Google search for public housing is better quality than the alternative, you don't turn up anything. Okay, so one point I want to make here is that your lead exposure has to do, at least in part, with your ability to access stable and safe housing. And that lead exposure can then function as a mechanism that links economic inequality to health inequality. That there are lots of reasons why poor people have poor health. This is one important one, and by identifying it, we understand where a solution can come into play. And And the way to interpret the wait list here, right, is that because we have not invested in enough units that people want, people are waiting, and their health is suffering as a result. And so what that means is, I mean, there's about 4 times as many people who would qualify for housing assistance as those who are actually receiving. So that means that millions of people are living with elevated blood lead, and they don't need to. All right, and so the final thing, this is the thing I want to convince you of, is thinking about how public policy related to housing assistance interacts with racism. So housing assistance is unique among safety net programs in the United States for how much it disproportionately serves Black families, right? So most safety net programs disproportionately serve Black families, but housing assistance is unique for how large the difference is. That if you look at food stamps, Medicaid, WIC, earned income tax credit, you're seeing about 20 to 25% of participants are non-Hispanic Black compared to 12% of the population. Housing assistance, it's 45%. Okay? But housing assistance is also unique among these programs for how difficult it is to access, right? That if you look at wait times for these other programs, they're relatively short. So SNAP is about 30 days for your application to be processed and then you get it. Medicaid can be up to 45 days, but it's usually much quicker than that. WIC, it's actually automatic if you are already receiving SNAP. And the earned income tax credit, because it runs through the tax system, really there's no wait time. It's just sort of automatic. Again, housing assistance 24 months, and that's the Minnesota wait time, but it's also the national wait time. And so the thing I want to convince you of is that these two descriptors of housing assistance are not they're not a coincidence. They're not an accident. It is because housing assistance disproportionately serves Black families. It is the one that is most underfunded relative to. Okay, that's it. Thank you all for coming. Happy to talk more. Some pictures here of America's greatest city.
Thank you so much, Andy. That was absolutely fantastic. Who has questions?
Hi, I'm Erica. I'm a PhD student here. And you're obviously, I think one of the major takeaways of the talk is like, we need to fund these programs more. Can you talk a little bit about like the incentives that exist now for developers to make this kind of housing, if any, and what you think we can do better, or what you think would incentivize building public housing more?
Yeah, great, fantastic question. What would incentivize more public housing construction? And there's a sad answer to that question, not much. The powers that be, those who have control over our orientation towards housing policy at the federal level, have already taken what I think is the wrong lesson from the past. I mean, the lesson they've taken is the lesson that many people have taken, that public housing was a failure. That when big government does big things, bad stuff happens. Now, I don't think that's true, but the outcome of that is that most of federal housing policy is now oriented towards vouchers. And so the idea being that vouchers provide the opportunity for families to leave terrible neighborhoods and move to good neighborhoods, leave bad housing and move to good housing. And vouchers do have their place in the ecosystem of housing assistance. And it was not until recently that an expansion of the housing voucher program to the level seen in these other programs was on the table. So in the Build Back Better plan in its first incarnation, fully funding vouchers such that anybody who qualified could get one was part of it. Didn't pass, but it's nice to hear that as part of the conversation. I mean, there are issues, of course, with doing that in a simple way. It would be nice to move back to funding public housing, but that's probably not gonna happen.
That was awesome, Andy. Thanks. So in the absence of that, what are the alternatives? What do you see as the mechanism here? Is it because, like, housing vouchers are putting people on housing that isn't being inspected as frequently? Should inspections go up? Should there be dedicated funding for lead abatement? What needs to happen?
Yes, a fantastic question. So I think if this is speculation, but the simple explanation for why public housing is most of the action here, and this is where maybe I shouldn't criticize the New York Times too much, but there's just much more potential for dedicated public pressure towards a public entity to improve the quality of their housing. So if you're a voucher tenant and your unit is not wonderful quality and you fear you're exposed to lead, you have little recourse. I mean, you could leave with your voucher, you can tell the housing authority, and that one landlord can get in trouble. But if you're a group of tenants in a public housing development, there's just much more power potential there to force housing authority to do something. And because it's a public entity, there's just much more expectation of accountability. So I don't know for a fact that that's what's going on. But I suspect that it's much easier to push public housing authorities to do things that private landlords don't have to abide by.
Hi, my name is Chris. I'm with the Minneapolis Health Department. I'm a lead risk assessor there. I was kind of curious as to where a lot of this media attention is coming from, like what they're looking at, because we're actually in the homes of people with lead exposure. We're also doing inspections to prevent lead exposure. And a lot of times when we respond to somebody who's in public housing, we find that the source is actually from somewhere else. Most of the funding from HUD went initially to address public housing, and then we've got programs that address it in private properties now too. And that's where a lot of our work is based. But like, I'm not really sure that, like, when it comes to media messages, I haven't really been taking that housing has really been the focus of, you know, anything that I consume media wise. So I'm kind of wondering where that comes from.
So I will say that I don't read the Star Tribune or any local paper, so it's possible that's being covered there as well. But having been like in the large catchment area of the New York media market, and the New York Times being what it is, these sorts of stories get a lot of attention. So like I would see these things shared on Twitter by left-leaning people kind of saying like, look at what NYCHA is doing. And so it's possible that this is limited to the New York market. I don't think that's true. I think that because the New York Times is what it is, things that happen in New York get outsized attention relative to what they would get elsewhere. And another point I would want to make is that the New York Times is not covering private landlords, right? The New York Times is not taking 1,000 complaints from people living in low quality private housing and saying, look at what private landlords are doing, because it's not clear what the solution to that is. Like this has a clear solution: get NYCHA to be better and get the New York City government and HUD to pony up money to improve quality. So I understand why there's more pressure on housing authorities than there is on an arguably larger source of the problem.
Yeah, because what we've been finding is that it's really hard to get participation from private property owners because it isn't necessarily a priority for them until they receive lead orders from us. And then we enroll them in a grant to help with, it makes it a lot smoother for the tenants if we're involved with doing the contracting and relocation and everything for that. But I guess, you know, in my experience, when we're meeting with families, a lot of times, the ones that are higher income are often shocked that is still a problem. Whereas our lower income families, it's like, you know, this might be our fourth visit with them because they've been through 4 different properties with their children and stuff like that, and they're just exhausted.
Yeah.
So yeah, I guess I feel like our public housing program, because it got the early funding and a lot of lead hazards were actually abated. When we talk about lead hazard reduction, we've got interim controls, which are meant to be like temporary, and then there's abatement, which is like 20 years plus. And so public housing is, mostly been held to the level of abating lead hazards, whereas private properties are going to continue to be a problem because we can't afford to actually abate them.
Yeah, that's a great point. That could explain the pattern of results.
I just had a question in terms of maybe kind of an extension of the study. So this particular study is looking at quality of housing, right? But I'm also wondering about quality of life. And so how you're finding, have you also thought about looking at not only people's exposure to lead, but actually what their quality of life might be across those different types of housing assistance programs?
Yeah, so good question. The survey that we're using in this case, NHANES, is not the best source for answering that question, largely because NHANES is smaller than other surveys that we could potentially use, partially because they take so much material from people, and so it's extremely expensive. However, the other survey that is linked to housing records is the National Health Interview Survey, much bigger, self-reported outcomes, some of which are related to what you could call quality of life, mental health and psychological distress. And the interesting thing there is that for both adults and kids, what you find is that the action is in public housing. That improvements in mental health are larger for public housing than they are for vouchers. Yeah, so I actually did that work years before any of this lead stuff, and so that surprised me that public housing has such positive effects, but it primed me then to not be surprised by this.
So we are at the top of the hour. I want to say super thank you to Andy for giving such a exciting seminar. And there is going to be some setup for a lunch in this room very shortly, so people can linger for a little bit, but then we're going to need to scoot ourselves out and maybe go into the conference. But thank you very much, everyone, and see you next week.